Hello, Tim Hart here to talk to California Doctors of Optometry again about the Primary Eye Care Network's Medical Eye Care IPA project. Our first presentation generated a lot of comments from you. We listened. The purpose of this presentation is to respond to your questions and concerns, simply and directly, and to invite you again to help our profession go forward with this project. First of all, what's our goal? It's to build an independent practice organization, IPA for short, that will represent and support independent doctors of optometry in expanding their practices to offer comprehensive medical eye care as well as vision correction, and to function as members of an integrated primary health care team. Well, what is an IPA exactly? It's a group of licensed providers who incorporate to contract with HMOs, employers, and other providers for their services. In IPAs, these providers retain their traditional practice autonomy while integrating themselves into self-directed groups that solve common problems and exert political influence within the managed care system. What will the IPA do for independent doctors of optometry? Compete to offer and be paid fairly for comprehensive, non-surgical medical eye care. Negotiate with health and vision plans, medical groups, and other healthcare organizations from a position of strength as members of an integrated and credentialed network, and provide for a framework for the profession to anticipate and capitalize on changes coming to California's healthcare marketplace. Medical doctors have organized themselves this way in this market for some time. Optometry never really has, and we believe, thus far anyway, that we are the only ones out there with a feasible proposal to do so. The IPA will be structured legally as an optometric professional corporation, owned and controlled by licensed doctors of optometry. Medical doctors may participate in optometric corporations, but ODs must control at least a majority of total shares. By definition, the corporation's owners will share in the IPA's profits and losses over time. The IPA will be regulated by the Department of Managed Healthcare as a risk-bearing organization, not as a Knox-Keene licensed vision care plan, as is the case with existing vision plans. The goal here is to serve only one master, you, the independent practitioner. The IPA will contract to accept capitated and subcapitated risk from other IPAs, institutions, and risk pools for the provision of medical and vision care services. The IPA will make a priority of developing, affiliating with, or participating in institutions organized to improve patient outcomes through coordinated care. Two examples are accountable care organizations and patient-centered medical homes, initiatives that are receiving federal financial incentives right now to produce savings in the Medicare and Medicaid programs. The IPA will work hard to affiliate with all three colleges of optometry, both to enhance its reputation and to develop and assure adherence to consistent certification, practice, quality, and outcomes standards. Our conversations with school administrators and faculty tell us that they believe now is the time to get organized for the future. We've identified two possible organizational models for the IPA, a single statewide IPA or distinct regional IPAs governed by a unified board of directors. Which option is chosen will depend on potential contracts identified in the Phase 2 business plan as the greatest targets of opportunity. For example, if the earliest possible contracts are statewide, the first option might make more sense. For local plans and demonstration projects that target specific patient populations, closer management by a geographically oriented IPA might be better. Because our market will change dramatically over the next few years, having the flexibility to adapt is paramount. There are three principal approaches the IPA could take to agreeing to accept risk in this market, each with its own advantages and disadvantages. The first is direct contracts with health plans, consisting primarily of agreements with county-operated health systems, local initiatives, and other commercial Medicare Advantage or Medi-Cal plans. One advantage here is that health plans bear an ever-increasing burden to demonstrate efficiency and quality of outcomes, so our model may appeal to them if significant savings can be achieved. A second option is IPA to IPA agreements, in which the optometric IPA assumes risk of loss for member optometrists and possibly ophthalmologists from another delegated IPA. Like health plans themselves, and for similar reasons, medical IPAs are looking for ways to shift risk and reduce costs, particularly for Medicare Advantage patients. The third approach is to contractors seek funding from public and private payers for unique managed care demonstration projects, including full carve-outs of all comprehensive eye care services under a full or risk-shared agreement, development of, affiliation with, or participation in accountable care organizations and patient-centered medical homes, and projects directed at a specific line of business, such as Medicare Advantage, commercial plans, healthy families, or Medi-Cal. Our schools, with their existing institutional and clinical activities, represent ideal practice centers for demonstration projects, and as such would be well positioned to operate, test, and generate reliable data on the OD as primary care specialist model, with significant built-in time and cost advantages. Implementation of federal reform requirements to prepare for mandatory offering and purchase of defined coverages and benefits in 2014 began almost immediately after the Federal Affordable Care Act, ACA for short, was signed in March 2010. The list of reform milestones is extensive. Here are just a few that are especially relevant to optometry. Effective this year, health plans are required to demonstrate that their non-medical expenditures do not exceed 15 or 20% of their total annual premiums. If they do, they're required to rebate premiums to their subscribers. This puts pressure on them to both achieve greater savings in capitation and to outsource overhead. The ACA phases into Medicare this year and next a number of prevention, wellness, and chronic care incentives designed to improve outcomes and reduce costs, such as centralizing care in patient-centered medical homes for Medicare, Medi-Cal dual eligibles. Our Medicare parity helps us here. In 2013, Medi-Cal reimbursement levels for primary care physicians will increase to 100% of Medicare. Resulting incremental cost increases here will be paid from federal funds. Effective January 1, 2014, discriminating against patients based on health status and among state licensed providers by health plans will be prohibited. Medi-Cal eligibility will be expanded to 133% of the federal poverty level for adults under 65. Full federal funding will be made available to cover the expanded population. Right now, it's estimated that by 2015, 1 in 5 California adults will be insured by Medi-Cal. In 2014, almost all individuals will be required to purchase health insurance or pay a variable penalty. Employers must play or pay. If they have one or more employees buying insurance through a state exchange and receiving a federal tax credit rather than from them, they must pay a per-employee penalty. State exchanges will define minimum levels of benefits that must be offered by health plans. By the end of 2013, the Federal Department of Health and Human Services is required to flesh out 8 broad categories of essential benefits that exchange policies must cover. Pediatric vision and hearing care is one of those categories. California is well ahead of all other states in preparing for full implementation of the ACA. Each state is required to establish a temporary coverage pool for high-risk patients. Our managed risk medical insurance program has been insuring at-risk children and adults for 2 decades. Their new pre-existing condition program began enrolling eligible beneficiaries last October. California's Department of Healthcare Services has already received federal approval and has begun to move all Medi-Cal and medically indigent beneficiaries into managed care rather than fee-for-service programs over the next decade. The California Health Benefits Exchange was created last year. Its board has been appointed, has met 4 times to date, and has already applied for a federal Level 1 implementation grant that will enable it to hire 75 full-time equivalents to implement federal law fully and on time. Close to 1,000 practicing OD should be certified to diagnose, manage, and treat most glaucoma patients independently by the end of this year, with more being added by licensees from each graduating class and continuing certification. You know you now can use many more TPAs without medical supervision, employ more in-office diagnostic tests, including taking blood samples from diabetic suspects, and can order imaging that will improve treatment, speed referrals, and reduce costs. Besides being primary eye care specialists, trained to diagnose, treat, and refer diseases and conditions specific to the eye and its adjuncts, you're trained to detect a high number of high-risk, non-systemic diseases and conditions by taking detailed patient histories, performing comprehensive eye exams, and taking intraocular images. Given the coming shortages in available primary care physicians and physicians' extenders to take on up to 8 million newly insureds, ODs, who are more available and accessible to screen and refer at-risk patients, represent a potential primary care asset too valuable to be ignored. As we've already explained in detail, Phase 2 of our project would consist of 7 discrete tasks to be performed by contractors retained for Phase 1, falling into 2 categories. Doing all legal work necessary to incorporate the IPA and create its administrative structure, and finalizing a business plan and budget to capitalize the corporation and begin operations. It will take a maximum of 4 months from date of start to complete Phase 2. How soon we get started will depend on how soon we receive your help. The estimated total cost for Phase 2 is $170,000, as portrayed here. We understand that being busy professionals focused on providing the best in eye care, to you the world of managed care is bewildering at best. We've done the research on your behalf, and here's what we know. California's market is mature, complex, and changing, seemingly by the minute. Optometry has a lot of ground to make up if it expects to become a player and hold its own in integrated medical eye and primary care. The next 3 years promise extraordinary risk and reward for all healthcare professions. Ours is positioned better than most to secure its future, if it acts now and in an organized way. The profession needs an organizational agent of sufficient scale to negotiate and provide services efficiently, to minimize ongoing management and compliance costs, and to be flexible enough to accommodate market-wide, regional, and local changes. We've identified a model that meets those criteria, but we can't proceed without your support. Please donate today using your PayPal account or credit card. If you're viewing this online, simply click on the Donate button on this slide. If you're viewing this on YouTube or on your mobile device, please go to primaryeye.net/IPA/#donate. Or mail your check to Primary Eye Care Network, Attention IPA Project, 3000 Executive Parkway, Suite 310, San Ramon, California, 94583. Please make your checks out to Primary Eye Care Network and put IPA Project on the memo line. Thank you again for your time and continued interest.